Hi, my name is Brian Apavu. I am a neurologist with an interest in philosophy, the mind, and living the examined life. Today, I want to dive into a specific epilepsy condition that we identify in children and are increasingly seen and managing in adult patients as they continue to age, and that is Dravet syndrome. Dravet syndrome is a severe, lifelong, developmental epileptic encephalopathy, most commonly caused by pathogenic variants or mutations to the SCN1A gene, leading to a loss of function of the NaV 1.1 sodium channel in GABAergic interneurons, which results in drug-resistant epilepsy and multisystem neurodevelopmental impairment. Dravet syndrome is rare, with an estimated incidence of 1 in 15,500 children. The onset of Dravet syndrome typically occurs in the first year of life, most often between 4 to 12 months of age, and often presents as prolonged seizures associated with a fever or not that can result in generalized grand mal or generalized tonic-clonic seizures or hemiclonic seizures, those where you have jerking or twitching of one side of the body. Initial seizures are often prolonged and triggered by fever or infection. And over time, multiple seizures start to develop, including myoclonic seizures, generalized tonic-clonic seizures, focal seizures, and atypical absence seizures. Neurodevelopment tends to slow down, intellectual disability occurs, and there ends up being motor impairments and behavioral disturbances, as well as sleep problems, and often autistic traits that emerge after the first year of life. Status epilepticus, or prolonged hard-to-control seizures, remain common with Dravet syndrome as children get older, and seizures are often triggered by fever, heat, or light. While seizure frequency and severity might reduce in adulthood and adolescence, generalized tonic-clonic seizures, often occurring mostly at night, typically persist, and complete seizure freedom is rare throughout life. Developmental slowing becomes evident in the first year of life, most often with individuals developing moderate to severe intellectual disability as they age into adulthood. Cognitive deficits are pervasive and often affect visuospatial skills, sensory and motor integration, executive function, as well as expressive language. These impairments don't typically improve even if the seizures lessen with age and become relatively better in terms of their control. Motor dysfunction emerges in early childhood and can manifest with hypotonia, ataxia, incoordination, or a characteristic crouched gait. There can be cerebellar features such as dysarthria, intentional tremor, as well as eye movement disorders that become more prominent as children enter adolescence and adulthood. And if not addressed, orthopedic complications such as kyphosis, scoliosis, and flat feet may occur. And if these aren't untreated, they can worsen mobility. In terms of the genetics of Dravet syndrome, it is almost exclusively caused by a loss of function mutation to the SCN1A gene. This gene encodes the NaV 1.1 sodium channel. The mutations or pathogenic variants to this gene result in haploinsufficiency, leading to impaired inhibitory GABAergic interneuron function and resultant network hyperexcitability in the brain. Gain-of-function mutations in SCN1A are not associated with Dravet syndrome, but instead these cause other distinct conditions, such as familial hemiplegic migraine type 3, and as well as it's been associated with other early-onset epileptic encephalopathies, with different clinical features and different treatment responses. The type of SCN1A mutation, whether it be a truncating mutation, a missense mutation, or another form, doesn't really seem to reliably predict the effectiveness of seizure medications for Dravet syndrome. Large clinical cohort studies and retrospective studies have shown that response to anti-seizure medications, including the typical recommended triad of valproic acid, clobazam, and stiripentol, which I'll discuss in a little bit, it does not significantly differ based on the SCN1A mutation subtype. Importantly, sodium channel inhibitors such as carbamazepine, phenytoin, and lamotrigine, oxcarbazepine are considered to be, are recommended to be avoided in classic Dravet syndrome, as they can worsen seizures due to further reduction of sodium current in already compromised inhibitory interneurons. Mutations in other genes, such as GABRA1, PCDH19, SCN2A, SCN8A, these can produce Dravet-like or overlapping phenotypes, but they're best considered distinct genetic epilepsies and genetic epileptic encephalopathies at times with their own clinical and therapeutic implications. We want to differentiate these from Dravet syndrome. While these conditions may mimic Dravet syndrome, they often have unique features or unique treatment responses, and some may benefit from sodium channel inhibitors or targeted therapies that may not be beneficial or may worsen seizures associated with Dravet syndrome. In terms of EEG characteristics, the EEG is typically normal at the onset of symptoms related to Dravet syndrome in infancy, but it later evolves to showing generalized slowing as well as multifocal epileptiform discharges. There are no pathognomonic EEG patterns that exist to distinguish and differentiate Dravet syndrome, but this slowing in epileptiform activity is fairly common. The clinical severity of Dravet syndrome is highly severe, with frequent refractory seizures, high risk of status epilepticus, and increased risk of mortality, often sometimes related to sudden expected death in epilepsy. There are reported cases of milder forms of Dravet syndrome, although they're few and unusual in terms of the literature and not the norm. Attention deficits, impulsivity, hyperactivity, anxiety, obsessive traits, and autistic spectrum features are relatively common with Dravet syndrome, and they should be looked out for. These behavioral issues may slightly improve with age, but they tend to be a significant contributor to disability and reduced quality of life for adolescents and adults with Dravet syndrome. Sleep disturbances, autonomic dysfunction, and thermodysregulation, or difficulty regulating body temperature, are frequently reported in children with Dravet syndrome. And as I mentioned, SUDEP, or sudden unexpected death in epilepsy, as well as premature mortality, remains a significant risk throughout life as compared to the general population. Dravet syndrome significantly impairs quality of life for patients and families due to the persistent seizures, the neurodevelopmental deficits, as well as behavioral problems. Most individuals require lifelong multidisciplinary care and support, and seizure freedom is rarely achieved. Most adults with Dravet syndrome remain highly dependent in terms of their activities of daily living, with only a minority, achieving any degree of independence. At least this is what we have reported in the literature. Quality of life is severely impacted for both patients and families, and multidisciplinary care is essential. Dravet syndrome does not self-resolve typically, and seizures and comorbidities persist throughout life. Though seizure frequency might reduce with age, the neurodevelopmental deficits remain a significant issue throughout life. In terms of treatments for Dravet syndrome, at present, the treatments are mostly symptomatic, meaning they are helpful in terms of reducing seizure burden, but we have a lack at currently in 2025 of disease-modifying therapies. Valproic acid and clobazam are supported as first-line therapies for Dravet syndrome by long-standing clinical experience and existing clinical guidelines. But the most robust evidence for first-line add-on therapy comes from randomized controlled trials produced in Europe involving stiripentol, as well as other clinical trials that have come out for the use of cannabidiol, the brand name Epidiolex, as well as fenfluramine with the brand name of Fintepla. Stiripentol's efficacy was established in two pivotal randomized placebo-controlled trials in Europe that showed that when it was added to valproic acid and clobazam, it led to a greater than 50% reduction in convulsive seizures frequency in about 67 to 71% of the patients studied. These results have been confirmed in meta-analyses and systematic reviews, which consistently rank stiripentol as a highly effective medication for seizure reduction in patients with Dravet syndrome. As a result of that, consensus guidelines now exist for valproic acid, clobazam, and stiripentol being part of the first-line therapies for Dravet syndrome. There is data supporting other anti-seizure medications as well. A landmark double-blind randomized controlled trial published by Oren Davinsky and colleagues in the New England Journal of Medicine in 2017 demonstrated that adjunctive cannabidiol at dosages of 20 milligram per kilogram per day significantly reduced convulsive seizure frequency compared to placebo, with median reduction being 39% in those receiving cannabidiol as opposed to 13% in the placebo. Subsequent randomized controlled trials confirmed this efficacy at both 10 to 20 milligram per kilogram per day dosages, with similar reductions and a favorable safety profile at that lower dose, at the 10 milligram per kilogram per day dose. These studies have helped lead to FDA approval for the use of cannabidiol for patients with seizure types associated with Dravet syndrome. Now, there are other meta-analyses and systematic reviews that further support cannabidiol's efficacy for seizures associated with Dravet syndrome, especially when combined with clobazam. We should bear in mind, however, that Epidiolex has been shown to drive clobazam levels up. And when clobazam levels become super therapeutic and toxic, that can lead to significant issues in terms of liver dysfunction. So if you're going to use Epidiolex and clobazam together, you want to be mindful of that. There might be a synergistic effect, but if you're not really following the levels well, you can end up with the risk of liver issues as well as sedation with really high doses of clobazam. In terms of fenfluramine or Fintepla, multiple phase 3 randomized controlled trials have shown that fenfluramine at dosages of 0.4 to 0.7 milligram per kilogram per day produce robust reductions in monthly seizure frequency, 45 to 65% greater than placebo, with responder rates of 70 to 73%, response being greater than 50% reduction in seizures. These studies also demonstrated durability of effect and a favorable safety profile with no cases of valvular heart disease at approved dosages. There is thought to be risk of valvular heart disease with the use of fenfluramine. So typically when it's recommended, there is a baseline echo and serial echoes performed to make sure that this valvular heart disease does not occur. As a result of these randomized controlled trial studies, fenfluramine or Fintepla, the brand name, is now FDA approved for Dravet syndrome. There are network meta-analyses as well that have consistently ranked fenfluramine among some of the most effective therapies for Dravet syndrome. When traditional anti-seizure medications don't work, ketogenic diet and vagal nerve stimulation may help in some patients. And as I mentioned, we want to try to avoid sodium channel inhibitors like carbamazepine, lamotrigine, phenytoin, and oxcarbazepine in patients with Dravet syndrome because they have a loss of function mutation to SCN1A, and further sodium channel inhibition may worsen seizures and the overall clinical profile. As I mentioned, these anti-seizure medications that I discussed are symptomatic treatments. They treat the seizure, they reduce the seizures, but they don't get at the underlying cause and the underlying gene. While not clinically available at this time, there are emerging disease-modifying therapies that are coming about for Dravet syndrome that aim to address the underlying SCN1A haploinsufficiency and attempt to restore inhibitory interneuron function, moving beyond just treating the symptomatic seizures and having symptomatic seizure control, but also to potentially alter the disease progression and the neurodevelopmental outcomes that are associated with these diseases. ASOs such as STK001, formed by Tango Technology, is designed to try and increase productive SCN1A transcripts by blocking the inclusion of a poison exon, exon 20N, that leads to nonsense-mediated decay. This is thought to upregulate NaV1.1 protein expression in GABAergic interneurons, restore sodium current density, interneuron excitability, and GABAergic signaling, which reduces seizures and improves survival in preclinical models. These antisense oligonucleotides directly address the core deficit of SCN1A haploinsufficiency. In terms of gene therapy, AAV9-mediated SCN upregulation is being attempted with AAV9 vectors delivering transcriptional activators or SCN1A cDNA to GABAergic neurons, increasing endogenous SCN1A expression and NaV1.1 channel function. The goal here is to restore inhibitory tone and elevate seizure thresholds in preclinical models. There's also studies being done with CRISPR-9 systems designed to upregulate the endogenous SCN1A gene without altering the DNA sequence, selectively boosting NaV1.1 expression by interneurons and improving inhibitory synaptic transmission. This type of gene therapy, in addition to the AAV9 mediated SCN1A upregulation techniques, are thought to try to aim towards cell type specific correction of the molecular deficit that we see with SCN1A loss of function or Dravet syndrome. In terms of other novel agents, there is HM1A. This is a peptide. This peptide is a NaV1.1 selective agonist, which directly enhances sodium channel function in GABAergic interneurons, compensating for the reduced channel activity and improving inhibitory signaling. So ticlostat is an inhibitor of cholesterol 24-hydroxylase and is thought to modulate neurosteroid synthesis and glutamatergic transmission, indirectly reducing network hyperexcitability. It's not a disease-modifying agent at the genetic level, but may have broader effects on excitatory and inhibitory balance in Dravet syndrome. Clemizole and lorcaserin are agents that modulate serotonin signaling, directly influencing neuronal hyperexcitability and seizure susceptibility. These agents have shown seizure suppression in zebrafish and early human studies, but they do not directly address the SCN1A haploinsufficiency. Their mechanism is more symptomatic, though they may have disease-modifying potential if they do impact the network development. With Dravet syndrome, there are some misconceptions. Misdiagnosis can occur early on in infancy as simple febrile seizures, or other epilepsy conditions may be considered. There may be patients who get characterized as having Dravet syndrome or suspicion of Dravet syndrome, but they may have a different epileptic encephalopathy. Dravet syndrome, often in the first few years, is often thought to be self-limited or responsive to anti-seizure medications, and the evolution of the disease beyond the first year of life or beyond a point in the first 6 months to 6 years of life. With febrile seizures, some of these patients start to develop afebrile seizures, or they start to have seizures beyond 6 years of life. That's when we start to worry there's something else going on. To avoid mischaracterization of Dravet syndrome and avoid the fallacy of reification, which could be treating all Dravet-like syndromes in the same way, regardless of genetic cause, clinicians should do a number of things. They should prioritize genetic testing, including SCN1A and other relevant epilepsy genes in patients with Dravet-like phenotypes. You want to be able to integrate genetic results with detailed clinical assessments to distinguish Dravet syndrome from phenotypes related to other diseases. And you want to recognize that Dravet syndrome is a diagnosis that's highly specific to SCN1A loss of function mutations, so that you can find the right therapy, target the right anti-seizure medication that have a higher level of evidence to them. And then also, as time goes on, there may be clinical trials that come out of development. For patients and families, it's good to be aware of the Epilepsy Foundation and other organizations that are have resources to understand where these clinical trials are evolving and what stage, where these clinical studies are being done, and at what point they're in clinical trial phase, so that if you wanted to be enrolled in a disease-modifying therapy clinical trial, that you have the opportunity to do so. As with all of my videos on here, this is medical education, not medical advice. If you want medical advice that's specific to your situation, reach out to your clinical provider directly. This is just educational only. I want to thank you for your time. If you're watching this on YouTube, liking the video and subscribing to the channel would be greatly appreciated. If you're watching this on the Nostr protocol, I hope you found it helpful and enjoyed it. I hope you all have a wonderful day and hope to talk to you again soon.